I guess really quickly, there was a little tidbit of information I was going to come back around to and talk about when we were talking about DKA that I forgot to mention. So if you come up to a patient and you're doing your primary assessment, that initial assessment, you see approximately 40-year-old male lying supine in his living room, unconscious, unresponsive. We get to primary, and you notice he's got a respiratory rate of 36, and it's labored, right? Probably going to see that with Kussmaul's. It's very rapid. If you know that number of that rate, rhythm, and quality, how are you going to treat that patient? What are you going to do to manage that patient's breathing status? 36 and labored. Yeah. Right? To try to get them down to a normal level, make sure they're having appropriate ventilations. If he's not breathing effectively on his own, we have to breathe for him, right? So with that primary assessment, you should probably be bagging that patient. What happens if your partner is working on getting vitals for you, or fire's working on getting vitals for you, and they come back and say, oh, hey, dude, your glucometer is reading high. We need to do a little bit of critical thinking here, right? What do we need to step back and reassess? Okay, so we know he's unconscious unresponsive. Now we've probably got a good indication why he's unconscious unresponsive, if his sugar is high. What do I need to take a step back and probably adjust when it comes to my treatment of the patient? Huh? So guys, why is my patient breathing 36 times a minute with labored efforts? There's a point, there's a purpose for him breathing that fast, right? Do I necessarily want to try to slow that respiratory rate down to a 12 to 20 range in this case? No. Okay, so if he's breathing that way on purpose, if we can establish he's in DKA and we have rapid ventilations for a reason to offload more of that acid, do we want to slow that rate down necessarily? Probably not. So what might we change up? Put on a breathing mask on him, 10 to 15 liters a minute, and let him breathe with that rate, because there's a reason he's breathing at that rate. If we slow it down, we can take away from the body's own mechanism of offloading, that acid. Okay.
Are there instances when like slowing down the breathing rate would be helpful? Like, why would you plan on it?
So typically, if it's way too fast or too slow, you're not effectively breathing on your own. But you know, obviously in this case, you're breathing fast for a reason, so we don't really want to slow it down. Like if you've got a patient who's in just significant respiratory distress and they're breathing 30, 40 times a minute, that's only going to last for so long until they pass out. Typically, yeah, they're still perfusing.
So you have to use pulse and not perfuse.
Yeah, if your patient's pale, cool, clammy, and it looks like they're going into some type of shock, then yes, absolutely ventilate for them. But if their vitals check out fine, other than their sugar and they're in DKA, let them have Kussmaul's. Just put a non-rebreather on them. Does that make sense?
Yeah.
Because initially, guys, you're not going to know that patient's in DKA. You're not going to know that patient's blood sugar. So during that primary assessment, you're going to probably be bagging that patient, right? But once you get that information to say, oh, wait, he's in DKA, take a step back and say, I probably don't need to bag this guy anymore. Right?
You said DKA can be both in hyperglycemic and hypoglycemic?
No, DKA is only hyper. Okay. Everybody good? Okay. Immunologic. All right, guys, the biggest thing we're going to talk about today is recognizing anaphylaxis, understanding what's happening during anaphylaxis, what happens when we go into anaphylactic shock, and making sure we can differentiate anaphylaxis from, say, maybe just an allergic reaction, because there's two different things. Well, how do you treat anaphylaxis? EpiPen. Okay, if you give someone an EpiPen who does not need it, who is not an anaphylaxis and doesn't need that dose of Epi, we can cause big problems. All right, so what does the immune system do?
Body takes the body from foreign substances.
It protects the body from foreign substances. All right, how does it do it?
Alerts the body.
Okay, so it recognizes that there is a foreign body, a foreign substance, something that's not normally inside the body that those cells and the body messengers have a problem with. And it says, hey, 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 I don't like you. I got to get rid of you in some way, shape, or form. Okay, if we have a normal, moderate reaction to getting rid or reacting to a foreign substance, that's going to be an allergic reaction. If we have that dramatic, exaggerated reaction to a foreign body, then we're going to have an anaphylactic reaction. So we'll make sure you guys can hammer out the differences between that. Okay, so this is how it all starts. You guys like the little comic book? Ouch! Zap! Bang! Boing! Boom! All right, so how do you know, or how does it develop in your body for you to be allergic to something? Well, and for this purpose, we'll talk about anaphylaxis.
Random chance.
Random chance. Okay, so yes, that's true in a sense.
You have the initial exposure, and then your body stores it, and once you get exposed the second time, your body like breaks out.
So guys, that's the biggest misconception, is that the very first time you're exposed to whatever substance that you're allergic to is when you have that anaphylactic reaction. Guys, it can take multiple years of exposure to these what we call antigens before your body decides, hey, I don't like you and I'm going to freak out next time I see you. Okay, so for example, we're going to talk about venom right here. There's a lot of people who are allergic to bee stings. So this is saying when you get stung by a bee, it releases venom. Okay, this is going to be what we call the antigen, the substance that gets released in your body that is not usually in your body, right? It's an outside factor. It's venom, it's food, it's drugs, it's something that we expose ourselves to. All of these mast cells will get triggered to say, hey, I don't like whatever this antigen is. You are on high alert. Do everything within your power, everything possible to get rid of this antigen, to kind of flush it from the body, if you will. Now, it takes several exposures. You have to get stung by a bee at least once for your body to decide it doesn't like that bee venom. Okay, if you get stung by a bee, your body might say, venom, I see you, I don't like you, and I'm putting a marker on you. Next time I see you on my turf, right, next time you're in my body, crap's gonna go down. All right, and then that's when we have the battle royale, if you will. The next time that antigen is introduced into the body freaks out in the form of anaphylaxis. Okay, so it can take just a second exposure to an antigen, or it can be years. Because I've ran an anaphylactic reaction to a guy who was eating seafood, and he was like, never in my life. He was 30-something years old. I've eaten seafood day in and day out, and I've never had a problem. It just that random exposure, the body decided, hey, I don't like you anymore. You can't be in my body anymore. Next time I see you, I'm going to freak out. Okay. So after multiple exposures, when that marked antigen comes in the system again, all of the cells say, ooh, hey, you got a mark on your back? Nope, not good. Sound the alarm. And then we have a cascade of responses from the body's systems that put us into a state of anaphylaxis and will eventually lead to anaphylactic shock. Okay, so everybody's good with multiple exposures. It's not just the first time you eat shellfish. You blow up like a balloon and can't breathe. Okay. Now, anaphylaxis is a lot different than an allergic reaction. Give me an example of an allergic reaction. Maybe pollen. Okay, what happens if you're allergic to pollen? So your eyes water, your nose starts to run. What's another example of an allergic reaction? Animal hair. Okay, mosquito bite. What do you mean by that?
You start to itch and stuff like that.
Do what?
Sometimes the allergic reaction can cause you to start itching.
We're jumping into a different territory when it comes to that. So tell me what happens with a bug bite. So you have, let's say you get bit by a mosquito and your body just doesn't really like mosquitoes. For me, guys, it's poison ivy. If I brush up against poison ivy, I have a significant allergic reaction, like have to get steroid shots, all that stuff. It's bad. But you have a localized reaction, and typically it's only going to be to one system. So for pollen, it can affect maybe the respiratory system. We get the watery eyes, the runny nose, but we only have that system targeted. Poison ivy, mosquito bite, we have that localized, maybe a little rash, maybe a little swelling, maybe a little itching, but it's just that integumentary system, just the skin that's affected. Okay. When we start to have more than one system affected by this antigen, that's when we're moving into anaphylactic territory. Okay. So down here, if we have more than one of these systems affected, so again, integumentary system. Poison ivy, if I get it, it wreaks havoc on my skin, but that's the only thing it affects. Right? I try not to test the theory that if I am allergic to poison ivy, you can have several more exposures and an allergy can develop into an anaphylactic allergy. Try not to test that theory. We have like a bush in our front yard. We just laid mulch this past weekend and it has poison ivy growing in it. And I told my husband, I was like, that 10-foot radius, that's all you. I'm not going anywhere near it. Okay.
Does the word sensitization apply to that? Or is that different? Because that's in the chemical.
Correct. Yes and no. Yeah, I'll come back to that. So right now, with my allergy to poison ivy, my skin's the only area that's affected. If I got poison ivy again and I started to have difficulty breathing, or I had changes in my blood pressure, or my lungs, or my heart, we've moved into anaphylactic territory. Okay, so anytime that a combination or all of the above of your skin, respiratory, and cardiovascular is affected, it is now an anaphylactic reaction instead of just an allergic reaction. Allergic is localized to one system. Anaphylactic involves two or more systems. Everybody clear with that definition? Allergic reaction is a localized reaction only affecting one system. And then anaphylactic affects multiple systems, more than one. All right, so you guys might not can see. All right, what are these? Hives. Now, if you got bit by 27 mosquitoes, your arm might look like that, right? This is called urticaria. All right, that's a fancy pants term for hives. We will typically see they will be bumps, like a rash type of, appearance, and it'll be raised a little bit, kind of like a welt. Like if you get bitten by a mosquito, you have that little raised surface for a little bit, then it goes away. So if you have these pretty widespread on your patients, and you see just this, only this, no other signs and symptoms, that can be an allergic reaction. But if you see this and you also have a patient who has difficulty breathing, please have an EpiPen somewhere around you, okay, because we're moving into anaphylactic territory. So it will affect the integumentary system by the urticaria or the hives. Usually we will see these where? Usually on the core, right? On the neck, on the chest, and on the abdomen is typically where they present most frequently and most obvious. Why do you think that happens? Okay. If we go into the point of anaphylactic shock, all right, what is happening? What's the definition of shock? Hypoperfusion. What does the brain say to my limbs and my extremities versus my core of the body?
We don't need those extremities anymore.
Sorry, extremities, you're great to have. I don't care if you get perfused. I'm going to blank the blood to the core of my body, shunt the blood to the core of my body so my vital organs get perfused. That's usually why we see them more so isolated to the core, because of that shunting if we're getting into the shock territory. Whoa. Right? Swelling. Yes, sir.
Quick question, can hives come out kind of out from something else? I know it's someone who's like a little bit stressed.
Yes. So that would still, it's funny because that's probably a chemical response from some of the chemicals released in the body during stress. But as long as it is just hives on the skin and there's no other signs and symptoms, then technically that's an allergic reaction. But it can be stress induced.
Technically, it would be your allergic stress.
I mean, in a sense, yeah. Because of the chemical cascade, it could be just an over exaggeration to the chemicals that are released during that time of stress. All right, angioedema is also common. Okay, do you guys ever watch that? It's not a very good movie, but I remember the scene Hitch with Will Smith. What does he eat? Is it?
It was shellfish.
It's shellfish, and he's like acting loopy, and they walk into the drugstore, and his face is all like blown up like a balloon, and he sees himself in the mirror, and he freaks out. All right, so angioedema is localized swelling to the face, particularly the eyes. Okay, so if you eat some peanuts and you start to be kind of itchy all over, and then your eyes are starting to swell shut, again, I hope you have an EpiPen around, right? Or ALS is really close by. What also might we see this with? Does anybody know?
Is it a heart attack? This happened in the airport. I can't remember what it was.
Like in real life, or
I'm gonna take the passenger out of the plane.
okay? So it probably could be from a couple other things, but there is a phenomenon from a particular type of drug. Okay. So
Blood pressure drop?
yes,
Yes, it was.
lisinopril. Okay, patients can be on this medication for 10 years, and just all of a sudden they get what the doctors call a lisinopril tongue. It's a particular hypertension medication, and it causes angioedema specifically to the tongue. Now, if it were me and I came on scene and I saw this lady and she's sitting there with that massive tongue, probably my first instinct would be like, ooh, allergic reaction, anaphylactic reaction. But I need to take a step back, right? I need to look and see, does she have hives? Does she have that integumentary skin or system involved? Does she have any trouble breathing? Which she might, because her tongue is massive right now, right? Are any of her other systems showing signs of anaphylaxis? Because this has happened. I have had a patient that wasn't that bad, but it was swollen like they could barely talk to me. And they took lisinopril, and turns out it was just a reaction from the medication. So just be aware of the lisinopril tongue.
No, let's go.
Lisoniprile. Yeah. LIS. Listen. Yeah, I don't have to write it out. I had it right the first time, I'm pretty sure. Okay. But again, if we see these puffy eyes, particularly in the eyes, and we have the other systems affected, I'm definitely going to start thinking anaphylaxis. Okay, so what's going to happen to my respiratory system with anaphylaxis? What happens? Okay, bronchoconstriction, guys, to the point where it gets so those spasms, those bronchospasms, and that swelling gets so significant, it can follow up my mainstem bronchi and my trachea, and the swelling can be so severe that my airway, my trachea literally swells shut. No air movement whatsoever. Okay, the patient suffocates because they're not moving any air, they can't breathe. All right, so might start out with some wheezing. We might hear some wheezing that might progress to stridor. All right, because what does wheezing indicate? Bronchoconstriction. All right, but that's in the lower airway, right, down in the bronchioles. And if we move to stridor, what's happening to that swelling? That's an upper airway irritation, right? So moving up that trachea, those mainstem bronchi, that swelling shut, are you gonna need a stethoscope to hear stridor? No. Okay. Let's see. So we've talked about the integumentary system. We can see the hives at urticaria. We've talked about the lungs, bronchospasm, and also vasoconstriction to the blood supply to the lungs. What's going to happen with my heart and my vessels? Okay, so initially during that first anaphylactic reaction stage, what's going to happen to my heart? Okay, I'm going to have an increased heart rate for sure. The force of contractility is also going to be increased. All right, now this is going to come into play. My vessels are going to come into play because we can be in a state of anaphylaxis, which is just I have 2 or more systems affected. We typically don't throw in the effects of that circulatory system, of my vascular system, until we move into anaphylactic shock. So what do you think happens to your vessels if we're moving from a state of anaphylaxis to a state of anaphylactic shock? Global vasodilation. All right, massive vasodilation is not going to lead to appropriate what? Perfusion. Okay.
So instructor A,
Yeah.
if we have like this massive vasodilation and it's shunting all the blood straight to the core, why is it decreasing coronary flow and cardiac output?
Because everything vasodilates, so the blood supply to the heart itself gets drastically cut.
Okay.
Because on top of global vasodilation, we also have something else that doesn't help out that perfusion. What else happens to our vessels? They become leaky. All right, remember we were talking about septic shock. That's how patients can die from septic shock. We have that vasodilation, and because we have that bacteria that's kind of eating away at our system and our vessels, we have leakiness. We have permeability of those vessels, and you lose fluid even more. Hypoperfusion, not good. Okay, does anybody know what causes the leakiness of the vessels? What?
I don't know.
Huh? Histamine. Guys, what does histamine do normally in moderation? And in moderation, we like histamine, right?
It reduces inflammation.
Okay. So it does stimulate inflammation to a certain extent, but why? To increase blood flow to an injury site to promote healing from the inside out, because that's how we heal, right? We have increased blood flow. If you've ever sprained your ankle, if you roll your ankle and you have those ligaments and those tendons and those muscles injured, what happens to your ankle? It swells. All right, we get increased blood flow to that injury site, So all of those amazing properties of our blood can be extra, concentrated to that injury site, and we heal ourselves from the inside out. So histamine in moderation is good. When you get bit by a mosquito, what happens? Does it swell up a little bit? And eventually what happens to that swelling in that little irritation spot? It goes away. That histamine is targeting that particular area, have that increased blood flow, heal from the inside out, everything's good to go. Okay. Benadryl. Has anybody ever taken Benadryl? Why do you take Benadryl? It's an antihistamine. So I go through a crap ton of Benadryl if I get into poison ivy because I have so much swelling. It's an antihistamine. It goes and it cuts down on the swelling, so the pain is not as bad and it's not as uncomfortable. Okay, so in moderation, we like histamine. It promotes healing. It promotes that increased blood flow. But again, guys, anaphylaxis is a freaking drama queen when it comes to reacting to an antigen. So instead of a little bit of histamine, it is a massive dump of histamine. So that massive histamine release goes and targets those vessels, and that's what makes the vessels leaky. The leaky vessels from histamine on top of vasodilation is not going to be good for what? Perfusion. So on top of losing their airway, they go into a state of hypoperfusion, that anaphylactic shock. That's how the patients die for anaphylaxis.
So why do you start with it? Why does it make them leaky? What is the?
Because it's doing its job on crack, pretty much. Because, right, if you get bit by a mosquito, you have that localized swelling. That's a histamine release and a histamine response. But with anaphylaxis, it's a dramatic, exaggerated response to an antigen. So I don't know the numbers. So let's say if you get bit by a mosquito, there's 10 histamine cells, or that go and respond. Anaphylaxis is like 10 million. So it's doing its job, but it's just doing it way too much. It's promoting too much swelling and permeability. Because you get the swelling by making those capillaries around that area permeable to increase that blood flow there. So it's just doing its job too well. Okay?
Would that be a type of like hypovolemic shock?
Yes. Questions? No? Okay. All right, so typically, guys, we'll see the skin, the heart, and the lungs affected in anaphylaxis. We really start to see the game changer when we see the vasculature affected, vasodilation, permeability. We move into the anaphylactic shock because that's not going to be conducive to perfusion. Okay. You can see some nausea, vomiting, some abdominal cramps with an anaphylactic reaction because there's such a big epinephrine dump when this happens. Body's going into a stress mode, but the hormones that outpower or overpower the epinephrine. So sometimes you see that nausea, vomiting as well. Okay. Forgive the title, but you will understand why I titled it the Sexy Anaphylaxis Video when you start watching it. It is the video that I prefer that gives the most information, how it flows, but it's got just like really bad like 70s porn music in the background. So just don't listen to that part and just watch the video.
Oh,
It's amazing what a fresh perspective can teach us. Like realizing fishing
who really
isn't
wants to start a
about catching.
conversation right now?
Anaphylaxis is a systemic reaction that can occur when a patient who is allergic comes into contact with the allergen they have been sensitized to. Clinical symptoms may be mild, moderate, severe, protracted, or biphasic. The allergic response begins with exposure. As antigen molecules enter the bloodstream, they interact with IgE antibodies bound to mast cells and basophils. This union of antigens and antibodies produces a complex sequence of intracellular biochemical events in the form of a cascade. A signal sent through the IgE antibody to the cell's interior begins the sequential activation of a series of enzymes. This leads to the influx of calcium into the cell and the fusion of granules with the cell's external membrane. The result is degranulation with the release of histamine and other chemical mediators into the extracellular space. These mediators flow through the body and bind to receptor sites at target organs, producing physiologic effects such as vasodilation and increased vascular permeability. In the lungs, histamine produces smooth muscle contraction, which causes obstruction, wheezing, and shortness of breath. A combination of mechanisms results in myocardial depression. To overcome these life-threatening events, epinephrine must be self-administered without delay. Upon injection, epinephrine works rapidly at organ sites to counter the effects of chemical mediators, acting to constrict blood vessels and reduce vascular permeability, relax smooth muscles of the airway, and stimulate the heart rate. This generally reverses the most dangerous effects of an anaphylactic reaction, allowing time for transport to an emergency center for full professional care. However, in some cases, the continued flow of mediators prolongs the pathophysiological effects or produces a relapse of the anaphylactic state. A single dose of epinephrine is not enough to reverse reactions in these cases. Patients should be advised that if symptoms have not improved within about 5 minutes after the first injection, a second dose is indicated. A second dose of epinephrine may be essential to adequately counter the anaphylactic reaction. The understanding of anaphylaxis as a continuum, with the potential for a severe, protracted, or biphasic event developing after the initial phase, underscores the need for 2 doses of epinephrine to be readily available for patients at risk.
Okay. Am I good with that?
So how common is it for a patient to carry 2 EpiPens on them?
Typically, when you're prescribed an EpiPen, you're given a prescription for 2. Now, whether or not you keep one on your person and one at home or one in your car, hopefully your patient has both of them on you.
Hopefully.
But yeah, you typically are prescribed 2 if you have an anaphylactic allergy.
You just don't know if you need 2 until you need 2.
Well, I mean, you don't know you need 1 until you need 1. Like, that's with me, guys. I'm terrified that, like my kids will develop, because we fed both of them early on. We started giving them peanut butter and, like milk and like all these common allergies. But I'm terrified that they're going to have an anaphylactic reaction and we don't know that they're allergic. And we're not going to have an EpiPen there, right? Like, you don't know until you know. So, yeah. Because I was like that paranoid parent. I was talking to the doctors, like, can you just like prescribe me an EpiPen prescription and I can just have it, and if I don't need it, I don't need it. Like, I don't know how that works. But he was like, yeah, I can give you one and you can go pay like $800 to get it filled because you don't have medical history. Yeah. Huh?
So when you put it that way.
I mean, that's another soapbox I can get on too, but we won't do that. All right, so.
These patients still need care.
Oh, absolutely. Guys, if you give somebody an EpiPen, it is going to be an AMA refusal if they say, no, don't want to go to the hospital. Because they could have that rebound reaction. They could need more epi. They could have some side effects from the epi in the form of like just arrhythmias or, something like that. So absolutely. After a little bit, after the epi wears off, yeah. Okay. Okay. All right, so guys, also too, it might be easier for y'all to understand what epi does if now you understand why we give it, right? Because why are we giving it? To reverse what? To reverse anaphylaxis, right? But particularly what's caused by anaphylaxis are we trying to reverse? Vasodilation and bronchoconstriction, right? We're trying to reverse that. So if you think about it, whichever way flip-flop you think about it, the properties of epi, the mechanism of action of epi is a vasoconstrictor and a bronchodilator. So it literally does the exact opposite to the system that anaphylaxis causes. All right. So guys, it's really important to, again, get that sample history from your patient, try to determine if they do have any allergies, okay? Because what if what's a side question we need to ask these patients if they say, oh yeah, I'm allergic to so-and-so, I'm allergic to peanuts. What do you need to ask? What happens when you come in contact with peanuts? If I say, oh, they give me a headache, do I care about that?
No.
No. Is that really an allergy to me in my medical eyes?
No.
No, but if my patient says, oh, I can't breathe and I get really itchy, yeah, I care about that. Okay, make sure that if they say they're allergic to something, we're distinguishing, is this just an allergic reaction? Is this just an untoward side effect? Or is this a true anaphylactic reaction? Because remember when we were talking about nitro? Patients say, oh, I'm allergic to nitro, I can't take it. Well, what happens when you take nitro? I get a headache. That's a side effect of nitro based on the way it works, right? That's not an allergy. So confirm it's an actual anaphylactic allergy before we kind of start freaking out. And if they say, oh yeah, I'm allergic to peanuts and I can't breathe and I get really itchy when I'm around them, what needs to be my next question?
We've been around them anytime recently.
Have you been around them recently, right? Especially if the complaint is, maybe nausea, maybe difficulty breathing, okay? Because a lot of people are pretty good at avoiding their known allergens. But I've had one student before who we did like a potluck, it was a Christmas party, and they're like, yeah, I can't, I'll just go get, Publix. I can't eat anything anyone brings because I don't know how it's made or what it came in contact with. So it might be that the patient ate something that they had no idea had that allergen in it, and they are now having a reaction. Okay, so make sure we're getting these allergies. Guys, there's 3 main groups of allergens. Okay, food, medication, and environmental. So food, your common ones are going to be nuts, peanuts, pine nuts, anything like that are very common these days. Shellfish, any type of shellfish like crab, lobster, crawfish, shrimp. Those are your 2 main, the very popular nuts and shellfish. Anybody here have an allergic or an anaphylactic reaction to anything? What are you allergic to?
Chocolate.
Sorry.
What?
Chocolate. I get a rash on my throat and it starts to swell up. My throat.
I'm sorry.
I'm sorry. Okay.
Do you have an EpiPen?
Yeah.
Huh?
Maybe it should taste sometime.
You're like, oh, we'll just inject myself. Worth it. So yeah, shellfish and nuts are the 2 main culprits in that food category. Medication, guys, just goes all across the board. A lot of allergies or anaphylactic allergies stem from antibiotics. So probably one of you guys in some way, shape, or form, a penicillin allergy is very, very common. If you are allergic to penicillin, you cannot have any family members of a psyllin antibiotic, or you will be allergic to that as well. There's amoxicillin, penicillin, there's different kind of varieties. Sulfa, is another big, that's actually one of my allergies. I had a really bad like head to toe rash when I was younger when I took a sulfa drug, and the rash was so bad my doctor was like, yeah, we're not going to chance for taking it again and going into anaphylaxis. You just need to list this as an allergy. So it happened a lot.
What is sulfa?
It's just a certain type of drug.
One of my friends in college had an allergy to sulfites, so we couldn't like drink any kind of beer or anything like that.
Chocolate and beer, damn.
Yeah, one of my
Awful.
friends is allergic to alcohol, specifically.
I had a previous student who was allergic to one of the key, I forget what it was, but one of the major ingredients in alcohol. Yeah. Particularly beer, though. NSAIDs, non-steroidal anti-inflammatory drugs, what is that? Aspirin, ibuprofen, Tylenol, all that stuff. That's another big culprit. This is a reaction that you can see. This is not common at all. You usually see this as a reaction to an antibiotic. It's topical. It's called Stevens-Johnson syndrome, but it gets so bad where the skin can actually like slough off.
Wonderful.
Yeah.
Like how many layers? Like this.
Like, yeah. I got red ancestry. Oh yeah, I think that's like the precursor to this. Like it didn't get as bad as me, but it's kind of like the same pathway. Okay, so again, if you see this on a patient but they're not having difficulty breathing or any other signs and symptoms of anaphylaxis, it could be a topical reaction to typically antibiotics. So this is going to go into the environmental. Okay, any type of like pet dander, any type of pollen or anything that causes a legitimate anaphylactic reaction, not just a runny nose during spring when everything's blooming. That's not anaphylaxis, right? Any type of venom is included in here. Okay, so bee stings, any type of ant bites, wasps, they hurt because they are injecting their venom into your skin. That's what you respond to, is the venom itself. All right. Chemicals, any type of, there's a lot of chemical makeups that go into certain body washes and deodorants and all of that stuff that some people are anaphylactically allergic to. Latex is a common / convenient allergy. If you will notice, most of the healthcare system has gone away from latex-based products, and they now are having nitrile-based products, especially like for gloves, PPE, that sort of thing. So that's a big question that your doctor will ask you before they use any type of equipment on you that might contain latex. So again, venom, bites, stings. Okay. These mother effers. Bees I'm fine with, but like hornets and wasps and yellow jackets are evil. Evil. Oh wait, I had one of like the big hornets in my backyard the other day. I scooped up my 3-year-old and I was like, we're going inside now. Yeah, I don't do well with buzzing insects. I was kind of traumatized when I was in kindergarten. If you guys haven't noticed yet, I have very thick curly hair, and it was like this.
Chef cook.
My hair was like down to here when I was in kindergarten, and one of the big carpenter bees flew and got stuck in my hair, like right here by my ear. So it was like I could feel the vibration and hear the buzzing in my ear, and I was freaking the F out. So anytime I hear like that, I'm just like, oh, no thanks. Yeah, but bees, they'll sting you once and they go away and they die. Right? Everything else can sting you multiple times. They're evil. So yeah. So guys, that's a normal reaction, right? Has anybody in here ever gotten stung or bitten by an ant and had zero reaction whatsoever? It's normal. Yes? What? No, no reaction, no swelling, no redness, no nothing.
Stick my foot in there.
Oh, yeah.
How did you come to find this?
I think he just told you, stuck his foot in there.
Yeah, no, okay, interesting. But this is besides Dorian, a normal response to getting bit or stung, right? We have a localized skin reaction. It stays just to that integumentary system, and then it goes away. It might be itchy, it might be red for a little bit, but then our body heals it. We get that histamine release in moderation, and it's gone. Right? This is normal, but when we get to the point where we're having difficulty breathing, those widespread hives, cardiovascular system's affected, we're moving away from allergy to anaphylaxis.
I have a question. So when I was younger, I got stung by a wasp on my calf, and it has been swelling for like 3 days. And it turned like really warm to touch and everything. Then I ended up having to go to the doctor to give me a shot. I don't know what kind of shot he gave me.
He probably gave you a steroid shot.
Okay.
Because that's how bad my poison ivy gets. Like it got to the point one time I got it so bad we were hiking and it got in my ankle, and so for the rest of the hike it was like rubbing it was really bad. I got like cellulitis from it, so I had to get like an injection of steroids and all that stuff. So it was just really bad skin reaction. Can't really see it, but that's just that little raise, that little welt, right? It'll go away. That's a normal response for any type of sting. Insect stings apply by ice. What happens with ice? When things get cold, they constrict. All right, so those capillary beds are constricting. We're not allowing as much blood flow. It's not going to swell as much. Guys, the swelling is what causes the discomfort and the itching because the skin is stretching. So if you vasoconstrict and you don't allow as much blood flow, the swelling will go down and it won't hurt as bad. Okay, that's a general concept for any type of sprain, injury, any type of skin irritation. It causes that vasoconstriction to the capillary beds, decreased blood flow, less stretching, less pain of the skin. Okay, so what's one thing we need to take into consideration? Let's say you get dispatched to Piedmont Park for difficulty breathing. You show up on the scene, you find your patient, and we're going through our questions, and we say, you're allergic to me, I'm allergic to bee stings. Well, have you gotten stung anytime in the past, few minutes? Well, I thought I felt it, but then it didn't really hurt, so I didn't think about it. If we can confirm that he's allergic to bees, and we have a possible exposure, that's one of the first things we need to do.
Check and see if it's got a sting there.
Okay, so maybe check and see if we've got a sting there. What else?
Check for other ants and check for.
Yeah, get him away from the environment. Because if he's sitting outside on a picnic bench and he got stung by a bee, what are the chances he could possibly get stung again? So if it's possible, if it's feasible, remove your patient from the environment that the allergen is in. So we don't have, either an exaggerated exposure or another secondary exposure. Make sense? If they're in a seafood restaurant and they're having an allergic reaction, we probably want to get them out of that environment as quickly as possible. Make sense? All right, again, guys, how do we treat? What's your treatment? Hopefully. EpiPen, what's your dose? 0.3 milligrams for an adult. What's your concentration? 1 to 1,000. Pediatric dose? 0.15 milligrams. And your technical concentration? 1 to 2,000. Okay, and how do you give an EpiPen? Okay. All right. So again, guys, we're going to be assisting the patient with this administration, right? Have you ever had to give yourself an EpiPen?
No.
Okay.
Well, I haven't had an allergic reaction since then. I stayed away from it.
Good. I don't want you to have to. But you will be surprised at the amount of patients who, if they're having that anaphylactic state, they just go into freak out mode and they forget how to use it type thing. So this is going to be a assisted medication, but you need to know you take it out of the case, you pop the safety off, the orange end goes to the vastus lateralis. You do what until you hear what?
Push until you're click.
You push until you hear that click, and then you
Oh, there, it's 10 seconds.
keep it there for 10 seconds. Do I go through the process of cutting off a pair of pants?
No,
Cutting off a long skirt?
no.
No. Guys, the needle, shorts, no. The needle's very long. It is designed to go through clothing, right? So just go on top of clothing unless they have 17 layers on. It might be in, different territory. If you don't have immediate access to this vastus lateralis, where else can you inject this? Gluteus maximus. Okay. So just remember the orange end is the action end. Give that appropriately. So guys, these are just some signs and symptoms that you might see for anaphylaxis, especially for the respiratory, cardiovascular, skin, and just other things. So again, some GI issues, nausea, vomiting, impending sense of doom, or a sense of impending doom. Remember that whole, oh shit, I'm about to die? It's a thing. We also want to know too, if progressively with these exposures to this allergen, if they've been getting worse and worse and worse, they might need that second round of epi. All right. We might just get a gauge of, is it trending to be a worse reaction every single time? Who do we definitely want to get en route to this call? ALS, because I can give multiple doses of epi. I can also do what if their airway closes up? I can put an advanced airway in. Okay, I can give other steroid-based drugs, smooth muscle relaxer drugs. So definitely have ALS en route if you can, foresee that with enough time.
So it's not any anaphylactic shock, just if there's some suspicion that the anaphylaxis is getting worse in the future. That we call it worse.
Yeah, because if it's just, because it can progress to the point where it started out as just like an allergic reaction, but if it's gotten worse and worse over time, this could be the time that it turns into anaphylaxis. And if they haven't previously had one, they're not going to have an epi. Okay. Guys, if your patient has a stinger still in their skin, what do we do? Remove it as best as we can with a flat surface credit card, your badge, if you ever get them, I'm sorry. But get your badge and just, okay, we're not gonna go in and like tweeze, remove it with tweezers, but we just wanna get it out because as long as that stinger is in there, it's going to release all the venom that is located inside that stinger until it's completely gone. So you can try to get it out so it doesn't release any more venom. Any bites or anything like that, wash with soap and water. That's literally your treatment at the registry level. Just wash it with soap and water, the area. Why do we possibly want to remove jewelry?
Swells.
Okay. So if there was any type of either localized or anaphylactic reaction, like say to my hand and my finger swelled up to like sausage size, if my rings were still on, I could cause some, vasoconstriction. They have to cut them off. I might lose blood flow to my finger, all that jazz. Talked about epi. All right. What's a contraindication for epi?
Technically ridiculously high tachycardia.
What's a contraindication for epi? Not in the book. In the book, There are contraindications for
cardiac
epi.
organ.
In the book, there are contraindications for epi. In the field, what is a contraindication for epi? Nothing. Guys, you are going to give epi first and ask questions later. All right, because I guarantee you, if you do not give epi when somebody's in a state of anaphylaxis or anaphylactic shock, they will die in front of you. Okay? Not so much a slow, painful death, an expedited, because it's a shit way to go. Right? You're sitting there, you're neurologically aware of what's going on, and you're suffocating from the inside out. Not pleasant to imagine. Give epi first, ask questions later. Okay? But after we give epi, how's that patient going to present? Jacked up on Mountain Dew. All right? Every time I've given epi, the patient is like just literally just like sitting there shaking and talking and be like, oh my God, what happened? Blah, blah, blah. Guys, your heart rate is going to go through the roof. Okay? Expect like around a 40 beats per minute increase. Blood pressure is going to be hypertensive. Respiratory rate is going to be what? Increased. Okay? And your patient's not going to be able to sit still. Right? They're going to be very anxious. They're going to be very restless. They're probably going to be crying because they had that near-death feeling and jacked up on these feelings. It's a weird combo. Okay? So usually within about 60 seconds or less of administering that epi, you're going to see those anaphylactic symptoms start to resolve. But it can take a full 30 minutes for that epi high to wear off. So your patient's going to go from one extreme to the other, right? I can't breathe at all. I'm about to die to, oh my God, let me go run a marathon. And there's all sorts of emotions running through my head right now. So what do you think after you give somebody an EpiPen, what we need to do? Talk to them. Let them know, hey, what you're feeling right now is normal. This is because I gave you this medication. It fixed what was going on earlier. You're going to feel back to normal in about 30 minutes or so. Because now they probably think they're going to die because their heart's going to explode. Right? So just talk them through it. But you can, depending on the age of the patient, depending on the medical status of the patient, we can have some complications if we give epi, right? What kind of complications can we have?
Put them into a dysrhythmia.
Okay, we can put them into a cardiac dysrhythmia. We can technically put them into, okay, so yeah, so VTAC. Sometimes we can put patients into a STEMI, all right? But that's if they have significant cardiac history and we give them epi. All right, so again, we expect a high blood pressure, we expect tachycardia. We don't really expect an arrhythmia, but it's not abnormal. Chest pain, headache, nausea, vomiting, all of this stuff is something that we need to educate the patient, say this is normal. I know it feels like you're dying again, but you're not. But just be aware that we could have some issues with that heart rate, with that heart rhythm, with the blood pressure. But typically, if the patient's in normal health, we don't really see any big side effects. All right, so this video we're gonna watch is, I'm assuming this video was made for educational purposes because this woman is in anaphylaxis. She's in her bathroom. I'll have to read the thing. I forget what she's allergic to, but she's having an anaphylactic reaction. And she's just sitting there, stridering away, just not breathing hardly. And she's like, her husband's just sitting there like filming. Like, I swear. And then I think at one point the husband's like, hey, you probably need to use your EpiPen now. And she's like, she gives herself, sorry. She gives herself the EpiPen, and you'll see within about 30 seconds. Oh my God, that was a bad idea. Okay. You'll see in about 30 seconds that stridor goes away and she goes to breathing normally, but then she's on the verge of tears because it's a scary experience.
In the book, it also says it's contraindication for hypothermia. I didn't really get it.
So technically, why would hypothermia be a contraindication?
It's a vasoconstrictor, so reduced blood flow, which would reduce.
Are you having a lot of blood flow to begin with if you're in a hypothermic state? No. So the research and the science behind that is, it's not going to do anything because your blood's not really perfusing like it should be. It's not really moving a lot, so it's not going to have any effect. And then also when the patient warms up, if that epi's still in the system and that blood starts flowing, it's going to be an amazingly bad rebound from a slow dormant state to now they're jacked up with epi in their system when they re-warm the patient.
It's pretty rare.
Huh?
On someone's hypothermia.
Yeah, no, it's not really a thing, but yeah. Okay.
Hello?
It sounds like it opens.
Okay, hold on.
Remix. Okay, so let's see if it says. Okay. So I guess with that one, there are certain chemicals that go into like perfumes and stuff like in fragrances. I guess that was what she was. Oh yeah. Hey, hon. Hope you don't die. It's about that time.
Go ahead.
Okay. Oh, that was the wrong thing. Questions, comments, concerns?